Okay, autoimmune thyroiditis is not uncommon. It's mainly affect women. Women are affected 10 times compared to men. And autoimmune thyroiditis could be silent without any symptoms and without thyroid dysfunction. But again, it increases the risk for thyroid dysfunction. And thyroid dysfunction itself can cause a lot of symptoms and can cause also some diseases, some infertility, for example, fatigue, and other symptoms, and in some cases could be dangerous for the patient. The probability to get pregnant with thyroid dysfunction is low. Sometimes it could be, but the possibility is very low. And if the woman while pregnancy has thyroid dysfunction, there is a risk for complications in the newborn. So it's very important to be with normal thyroid function before getting pregnancy and to follow up during pregnancy every month to be sure that the thyroid function are normal during pregnancy without causing any complications for the newborn in the future. It's a very simple test. It's a blood test for TSH, only TSH. If the patient has symptoms of hypothyroidism or hyperthyroidism, then we should add also T3 and T4. And if the tests show that there is thyroid dysfunction, we can also add a test for antibodies to the thyroid gland. All are blood tests. But if the symptoms are compressive symptoms or palpable nodules while examining the thyroid gland, we also should add ultrasound of the thyroid gland. There is a huge difference between the epidemiology of thyroid nodules and the epidemiology of thyroid cancer. The thyroid nodules are common, and the epidemiology speak about the possibility depending on the age. We know that in men it could be more than 30% in the old age, and in women it could be 50% at age more than 50 years old. So thyroid nodules are very common, but fortunately thyroid cancer is very low. We know that the most common thyroid cancer is papillary thyroid carcinoma, and it's about 12 cases in every 1,000 persons. So the thyroid cancer is very low. And we also know that the prognosis of persons with papillary thyroid carcinoma or follicular thyroid carcinoma, the most common carcinoma in the thyroid, is very, very good. Of course, if they are diagnosed at time and get treatment by surgery and sometimes iodine at time, and these interventions can keep the patient well and with cure of the cancer itself. Study is just to perform ultrasound, and by sonographic features and the diameter we decide if to perform puncture, FNA, from the thyroid nodule, and by the puncture we know if the patient has thyroid cancer or not. We know that 90% of the cytologic examination from the nodules reveal only benign test, and the other between 5 and 10% reveal suspicious or cancer finding that should be treated by surgery again, and sometimes iodine therapy. There are some indications that include cancer, also include goiter, that is enlargement of thyroid gland that cause compressive symptoms and difficulties in breathing and swallowing. Then we perform surgery. Sometimes there is goiter and descending thyroid, that there is enlargement of thyroid gland with the component in the chest itself. In these cases also we perform surgery. And also hyperthyroidism. In some cases the medication is not enough and the iodine is not option, so in these cases also we prefer surgery. We prefer thyroid operation to be performed by high volume surgeons. That means very expert surgeons, in order to lower as possible the immediate complication from thyroid cancer. And we know if the operation is made by high volume surgeon, the possibility of complication like hypoparathyroidism with hypocalcemia or vocal cord injury will be very, very, very low. And the long-term complication is just hypothyroidism. It's obvious because we operate the thyroid gland, and the patient should keep taking the thyroid hormone replacement therapy all the time with TSH follow-up to be sure that he is controlled.